Hi, my name is Josh Meeks. I'm an associate professor of urology at Northwestern Medicine. Today we're going to talk about BCG cystitis. BCG, we've been giving for bladder cancer since the 1970s. There's over 800,000 vials made every year to treat our patients with bladder cancer. Yet at the same time, how do we manage giving them enough to treat their cancer, but not enough to cause toxicity? And unfortunately, in many people, just a little bit of BCG is enough to cause too much toxicity, and we call that BCG cystitis. So at Northwestern, we figured out that in order to give BCG, which we actually give as an entire system once a month, providers from all of our sites get together and talk about the BCG allocation and how we're managing BCG, because we try to actually do this as an entire network. And so one question that commonly we began to address is, what do we do with those patients who develop BCG cystitis? Because it's one thing to be able to give the therapy, but you also have to be able to give the antidote. So the way that we developed our BCG cystitis algorithm was that we began with sort of experience that we developed from providers who've been treating patients for a long time and sort of our own working knowledge. A lot of that is based on the literature that's developed over the last 50 years for giving BCG. But then we actually have unique experience of having a urologic infectious disease clinic at Northwestern that is a infectious disease provider that's focused on urinary tract infections, who also has experience treating BCG cystitis. So we have sort of an integrated system here that's developed over years, and that as we sort of figure out, what can the urology provider do, and then at what point do we need to get infectious diseases involved, and how can we work together? So that's how the sort of algorithm started. And then once we had a system that we felt was pretty much the best practice of how we manage patients, then we kind of rolled that out and codified it and then provided that to all of our network sites. We see patients every 3 months during their first 2 years where we're doing cystoscopy. And yes, that's a diagnostic procedure, but it's far more than that. It really begins with the discussion of, how's your BCG going? What's it like for you? And everyone will have some symptoms. And again, we think to some degree that that's some evidence of activity. But what I start worrying about is people say they're miserable. So getting that knowledge before we do the cystoscopy is really helpful. And then when we look in their bladder, if it's fiery red and just full of inflammation, that's some evidence that their bladder actually is having way too much inflammation. Part of it is the patient's symptoms, part is what their bladder looks like. If we're really worried, we'll often get biopsies of their bladders to see, do they have granuloma, or again, is that cancer? And we obviously don't want to miss that. So that's part of it. And then imaging to really get an idea about where they're starting. What we've kind of seen as we started to approach this in a systematic way is that not only do we see from our own patients, number one, we're probably scaling back doses of BCG earlier, so we're picking it up sooner, which is really the key to this, because again, I often think about inflammation as kind of this, unrelenting wave of response. And if you stop it early, you can pull it back, but the longer it goes, the more severe the outcome. So stopping that early is the first thing that we see a little bit that's good. But we also see is that patients are coming in from outside the system, people have given them BCG, and their provider said there's nothing we can do other than consider bladder removal. So we see people who are years out and just been dealing with this. But again, if you start to manage your bladder in a way where you're trying to knock down inflammation, whether that be with anti-tuberculosis medicines or using steroid doses, you can actually begin to rehabilitate their bladder and bring them back to a quality of life that they haven't seen in a long time.